Thank you, Priya, and good evening, everybody. So today we have a very important topic, uh, which is death and dying, and we have three eminent speakers who all are experts. First of all, I would like to introduce Dr. Ros Taylor. Dr. Ros Taylor, she started her work as a GP in Cumbria, but later she became interested in palliative care and established a palliative care unit in West Cumbria Hospital. And in 1996, she took the leadership of Hospice of St. Francis in Berkhamsted, and she was in that position till March 2015. And her most or main achievement during her work was she was able to um, find out a site for new 14-bedded hospice building and overseeing the construction project and creation of the garden. Then she became the clinical director of Hospice UK, and now she has been a palliative care physician at the Royal Marsden and the Royal Brompton Hospital in London. Dr. Ros Taylor has a more than 26 years of experience in palliative care and has awarded a BE for her services to palliative care. And she has contributed to many books and recently a book on spirituality and hospice care. And she has also contributed to Lancet Commission on Value of Death. Welcome, Dr. Ros Taylor. And next, I would like to introduce Dr. Raj K Mani. Dr. Raj K Mani is CEO and chairman of Pulmonology, Critical Care and Sleep Medicine at Naidi Healthcare, Mathura. And he is a pioneer in the field of pulmonary critical care and in sleep medicine. And presently, he was the former president of Indian Society of Critical Care Medicine and is the chief editor of Indian Journal of Critical Care Medicine. He has a great partnership with palliative care, and he actually leads the end of life care task force in India. And all of you know that recently Supreme Court has a judgment on advanced care directives. He also had many articles, publications. He is trained in Delhi and Britain, and he is working at many other famous hospitals also. Welcome you, sir. And next, LIbby Sallnow. Dr. Libby is a palliative medicine consultant with the CNWL NHS Trust London, UK, and is also honorary senior lecturer at St. Christopher's Hospice and UCL Marie Curie Palliative Care Research Department, UK. And she has developed the fields of new public health approaches to end-of-life care, compassionate communities, and social approaches to death and dying and loss over past 2 decades in UK and internationally. And her PhD explored translation of a model of compassionate communities from Kerala to London, UK. And she has published many articles and book chapters and co-edited the book International Perspective on Public Health and Palliative Care in 2011. She's having various positions in international bodies. And she's also the president of palliative care section of Royal Society of Medicine UK. And she's the first author of the new Lancet Commission on the Value of Death, Bringing Death Back into Life, which was published in 2022. And welcome, Libby. So first of all, I would like to invite Dr. Ros Taylor Um, and she will be talking about death and dying in Euro-American countries. And each speaker has 20 minutes. So welcome, Dr. Ros Taylor, and it's over to you.
Thank you. Thank you very much. I'll just go on to slideshow. I presume you can all see my slides now?
Yes, yes.
Yeah, good. Yes, so thank you very much for that warm invitation and very comprehensive introduction. Yes, I have been a palliative care doctor for a long time, working at the bedside, but also locally and a little nationally in strategy. And I'm going to talk a bit about the inequity between the global north and the global south, what's going on in Europe, the UK and America, and the challenges we face, which are a bit different from the challenges you face, but there's a lot of similarity. So I will try and keep within my 20 minutes. So this is a quote from the Lancet Commission, which you're going to hear more of. We believe that healthcare globally now, for different reasons, healthcare has an unhealthy relationship with death and dying and grief. And the Lancet Commission focused on how to make it healthier. And you'll hear from Dr. Libby later on about some of the recommendations that we feel are global recommendations. So there we are. What binds us, wherever we work in palliative care, is that we are all managing suffering and uncertainty. We are managing symptoms, but we're also managing spiritual distress, social distress, psychological distress. And just a global focus, first of all, on a bit of data. There isn't too much data in my slide, but we know that across the world, in almost every country, life expectancy has gone up. There are pockets where it's actually gone down, and even in London, there's huge discrepancy depending on which borough you live in. So these are averages, but on the whole, even in low-income countries, middle-income countries, we are living longer, but inequity and inequality persist. But the other important thing is that although we're living longer, the number of years that we are healthy hasn't increased. And there's an enormous amount, as you know, of untreated, unpalliated health-related suffering, which was really quantified in the previous Lancet Commission, which I do recommend you read, as well as the Commission on the Value of Death, which was about global access to palliative care and pain relief. So a lot of suffering. But where I work, and if you live in Europe or America, death has disappeared from view. People die in hospitals, they die in care homes, they die in institutions more than they die at home. So that's what I mean by death has disappeared. People believe that they are immortal. These are a few books that are selling well in the bookshops in our local high streets. Immortality, How to Live Forever. And even yesterday, 5 days ago, 16th of March, the 9 rules to follow if you want to live to 100. Well, I don't want to live to 100, but this is how to do it. I can send you the article if you're interested. So some people would argue that we don't live in a death-denying society, but I see an awful lot of people who just want to live forever and are unwilling to have conversations about how they would like to be cared for if their health deteriorates. So a very brief focus really on what's going on in the global north. And by the global north, I do mean most of Europe, most of North America, including Canada, and does include the UK, which has had a pivotal part, I guess, in the emergence of palliative care as a specialty. Somebody will have to stop me if I go over 20 minutes. So many of you will have heard of Dame Cicely Saunders, who is, I think it's generally agreed, was the founder of the modern hospice movement in London. Following a donation, she set up St. Christopher's Hospice, which is still the flagship hospice in the UK. And many of you will have probably attended courses remotely or in person at St. Christopher's, and they're doing a lot of global education. And Dr. Libby is part of that. So that's 1967, not that long ago. The UK was one of the first countries in the world to have an end-of-life strategy, a national strategy. And it is interesting for me to read that again, which I did last week. We haven't made amazing progress. And that is, my maths isn't very good, 15 years. Slow progress, but some progress. And we keep producing national documents. This is one of the latest ones, which is interesting to read, the ambitions document. So if you are thinking about policies and guidelines for where you live and work in India, have a look at some of these documents, because many of the principles and concepts apply wherever you live. So those are the 6 ambitions. Professor Biwi, who is our National Director of End-of-Life Care, was the key author of this document. So if I think about hospices, which are mainly charitable institutions in the UK, there are about 220 hospices which have beds. So that's about on an average of 10 to 12 beds. So we have about 2,500 beds. Even if every bed was full, and even if everybody died in a hospice bed, we would still only be caring for 10% of deaths in the UK. And actually now many people don't die in the hospice beds, they go home if we can possibly support that. So most of our hospices are charitable. Most of our community teams and most of our hospital teams, actually there's a misprint there, that should say hospital, are in the NHS. And we believe that specialist palliative care reach possibly about 30% of those people who die. But we believe that there could be a need for much higher than that. But we're also much more interested now in how the community can support our dying people rather than just our specialists. And that perhaps is going to feature more in Libby's talk. So let me move on. So as I said, we are very good at producing national documents. We're not so good at implementing guidelines. These are 2 guidelines just in the last month, Dying Well at Home, and also actually quite a shocking document, which I would think applies to many countries in the world, looking at the impact of COVID-19 on death, dying, bereavement, on lonely dying, on unsupported dying. And in my opinion, we have gone backwards since COVID. It has highlighted inequity in the North, and I'm sure where you work too. And there have been some terrible stories of unsupported suffering. So as many of you know who have already studied the science of palliative care, we look at total pain, not just the physical, but also the psychological, the social, and the spiritual. And my feeling in the global North is that we are focusing much more on the physical side of palliative care, and we are possibly abandoning some of those early concepts of psychological, social, and spiritual care. And that's a message for you working in India, because it's often the psychological, the social, and the spiritual that make most of the difference to patients and their families, their loved ones, and their future life. So as I've said, the models we look at are a mixture of charitable in the UK, plus state-funded hospital and community care. In the USA, as many of you will know, there are insurance schemes, particularly to cover home hospice for people covered by Medicare insurance in the last 6 months of life. And there's quite a division between palliative care and hospice care, which we don't really see in the UK. And in Europe, in most of the countries, there's a mixture now of state-funded insurance and charity. And I guess that's probably the same as what's emerging in India now, a mixed model, which has its challenges. Palliative care became a specialty in the UK in 1987, 36 years ago now. It became a specialty in North America in 2006, and it is now a specialty, this is possibly a bit old, this data, 26 out of 53 countries in Europe. And once it becomes a specialty, there is a training program for doctors and usually in some countries for nurses to become palliative care specialists. But I'm less interested in specialists because I believe, like most of you on this call, is that palliative care is part of everybody's work, whether you're a doctor or a nurse. If you want to read exactly what's happening in the different countries in Europe, this is a really thorough WHO, very interesting briefing, looking at all of the different countries and where they're up to in developing palliative care services. So what are our challenges in the global north? We do want to reduce hospital deaths. In the UK, still around 48 to 50% of people die in hospital rather than at home where they would like to be. We also have a high number of care home deaths, which you won't have in India. So people either die in hospital or care home, and only 24% of deaths are at home. The last data, maybe 25%. We believe that people are being overtreated in hospital when their prognosis is very poor. That is a theme that I know Dr. Raj Gopal feels very strongly is happening in India. We are ventilating frail 94-year-olds with advanced COPD and lung cancer when they should be palliated at home with their family. We pay lip service to earlier palliative care based on Jennifer Temmel's study, which showed that early palliative care makes a difference. On average in the UK, we are still only getting referrals to palliative care in hospital and community about 7 or 8 weeks before people die, certainly not 6 months. We're still challenged by having advanced care conversations, mainly because we are quite death averse still. We have big challenges with our workforce in terms of palliative care nurses and doctors. So it's good to see anaesthetists and other specialties on this call. I've talked about immortality. We do not have the family networks that you have in the South. We have very small families, often living apart from grandparents or grandchildren, much smaller networks. So we're looking more at neighborhoods rather than family networks. And our care, although we have many services, the services are quite uncoordinated and fragmented. Sounds dreadful, doesn't it? But the thing we do have, which you don't always have, we do have medication. We are very lucky. I can get almost any medicine that I want, for my patients, within 10 minutes from a local pharmacy. And in fact, we had to make a journey this morning. We're discharging a very sick young man with advanced pancreatic cancer home. He wants to be at home for the last days of his life. His pain has escalated. We needed more opioids, and one of our volunteers drove down to the pharmacy to collect, and it's as easy as that. So I've mentioned place of death. Globally, 53% of people die at home if you take the world population, but there's massive inequity. As I've said, less than 25% in the UK die at home, but in sub-Saharan Africa, 98% would die at home. And one of the key problems in progress is lack of data. Deaths aren't registered, so you don't know the cause of death or where people died. And I don't know where you're up to with registering deaths in India. But if we don't have baseline data, then it's very difficult to measure progress. And just looking at my own country, 70 years ago, 80% of people were dying at home and death was much more familiar. Now, 80% die in institutions, or perhaps 75%, and people no longer witness death. And that's part of the problem. This is an interesting paper on just what I was saying on India's struggle to keep track of the data. We have 600,000 deaths in the UK per year. You have nearly 10 million. And you would have an amazing data set if you knew what people died of, where they died, who was with them, and you would be able to monitor progress in a way that's very difficult without this data. But just a word about home death. It is meant to be in the global north. It's a quality marker that it's seen as a good thing. But I work in quite a deprived part of London now, West London, where home isn't always a good place to live, and certainly not always a good place to die. And this was a quote from a patient we were looking after. As I've said, family networks are not the same, and I think you have much better networks to work with than we have. And I know I'm making generalizations, but I was thinking about who is in my hospice this morning, and we have 3 patients of Asian heritage with lots of family and visitors around them, and we have 8 white patients with very small networks. So that's a microcosm of what we're working with. Libby may mention this a bit more. This is one of Libby's amazing initiatives that has spread around the UK and is spreading where we are trying to create networks for those people who are dying alone, older and lonely. Where we haven't got families, we have got volunteers. So a word on opioids. Some of you will be familiar for this rather shocking map. In India, you grow 80% of our opioids, but you only have access, I think, to about 2% of that production. And this map is drawn in proportion to the use of opioids per grams per person. So it shows that most opioids are prescribed and used by the global north plus Australia. And it's quite a shocking map, really, because we know that although there's fear of opioids and there's talk of opioid crisis in our work, particularly with patients living with advancing cancer, opioids are critical to our work. We also have a lot of discussion about cannabis. I don't know whether that's an issue in India, but there's a big focus on cannabis and CBD, where I'm sure in America and in Europe. I've mentioned this concept of over-treatment, too much medicine. I think that is, as medicine progresses in low and middle income countries, there is a risk that you are following all of our bad habits from the global north. We are treating people for too long and too intensively where there may not be benefit, and we may be bankrupting the system and families. What if hospital was a safe and peaceful place to die? Well, it certainly isn't where I work. People are very frightened now, worse since COVID, of going to hospital. This was an editorial. I haven't published as much as Libby, but this was an editorial I wrote about palliative care in hospital a few years ago. We used to trust our hospitals, but certainly in the UK, people no longer trust their hospitals as safe places, which is a sad state of affairs. I've also had an interest in carers, family carers. This is a gender issue because most family carers are women. Most professional carers in palliative care, in hospice and in care homes are women. And yet there is some inequity. And during the writing of the Lancet Commission, we focused a little on gender globally and inequity. And this is really interesting. This is a study, I think, was in the UK, that women wait longer for pain control when they turn up in pain to an emergency department. So whether that's bias or maybe people think women can tolerate pain better, I don't know. But inequity is there everywhere we look at. And I think one of the difficulties in areas where you work, it's not just the writing of guidelines. The inequity is in the implementation and representation on guidelines. So we do have braver conversations. I don't know whether these happen where you work. What matters to you if time is short? Who matters to you? I'm coming to the end of my presentation. So we do have brave conversations, which I hope they are embedded in our work in palliative care, and they have spread to other specialties. But we do, as I started off by saying, we have a workforce crisis in the UK at the moment, driven by many, many things. Now, to become a palliative medicine specialist, you also have to do significant training in general internal medicine, which maybe you do have to do in India too. It's probably a good thing, but it is going to cause a bigger shortage of palliative doctors. We have a shortage of experienced palliative nurses. But in a way, there are new groups like paramedics training in palliative care, anaesthetists. I know there are several in this on this webinar. But it is the work of cardiologists and geriatricians and respiratory physicians to be able to care for all of their patients until the end of life and to understand symptom control, psychological care, and spiritual care. So this was an article I found that talks about palliative medicine, a great option for anesthesiologists. Well, my working life doesn't look like this, but I'm sure it looks like this for some of you. And one-to-one care and intensive care can be excellent palliative care, but only if it's for appropriate patients. This is a slide I love because I think the task of medicine in the future is to manage the gap between expectations and reality. If everybody expects to live till 100, then they are going to suffer. And what we need to do is have more honest conversations about expectations, because sometimes we cannot change reality. And if you close that gap, you are going to reduce suffering and promote healing. And I guess as services develop around the world, this is a model from another document that I recommend you have a look at, the WHO document on looking at the right to palliative care across the world. We do need policies and guidelines, but most of all, the baseline is empowering people and communities. Everything else will develop if our communities feel more empowered. So the value of death, the commission, which Libby is going to talk about, we believe death has value for individuals and families, especially for those who live on. For doctors and nurses, it's a very rewarding part of our work, an important part, but also for the human race and the planet to be able to do this better. And this is my final slide. Kath Mannix is somebody you may have heard of. She's a retired palliative consultant doing a lot of media work on trying to improve care of the dying, particularly in the UK. She feels that where we work in the global north, we've lost the rich wisdom of normal human dying, and it's time for us to talk about dying and reclaim the wisdom. And I guess in India, you need to make steps so that you don't lose the rich wisdom that I know you have. So I'm going to stop there. I'm going to stop sharing.
Thank you, Ros. I think next we will move on to Dr. Raj K Mani, who will talk on intensive care and dying in India. So, sir, it's over to you.
Can I share? Yeah, just a moment. So I'm going to give a different perspective, that of an intensivist. We all know that life is a composite whole, life and death. Cloud never dies, said Thich Nhat Hanh, the Zen master. That's a cloud becomes water, water back to cloud. So it's a cycle. So this composite wholeness of life and death is looks intuitively so clear, but in practice, we lose our this view. We seem to look at life as a want to prolong it, want immortality, and there's a gap between appearance and reality, of course, which Ross just now showed us. This gap is quite wide and accentuated by the apparent advances in medicine, advances in technology, all the romance of technology and intensive care environment leads us to many an end like this. Something which looks like fate worse than death. So not being unnecessarily prolonged, death not being unnecessarily prolonged is one of the criteria of good death. There are 11 of them that have emerged from a systematic review of systematic reviews, right? So this is very important. This particular kind of medicalized death is extremely common in India, very paradoxically. While there is a large number without access to very basic medical care and certainly to modern medical care, there is that segment of population which aspires to high-tech medicine, and they also end up very poorly. So you can see excess or the futile care harms the patient, harms the ethical environment, and the family it harms immensely in terms of emotional burdens and financial burdens and all kinds of practical worries and problems. And also the caregiver, in pangs of conscience, we have moral distress, and we can't see this going on without losing our sensitivity and getting depersonalized. Healthcare systems, they're already very strained in this part of the world. Very clearly, very obviously, we are having resource misutilization, the extent to which we have not measured very well, but national sample survey of more than 100,000 people show that any intensive care admission deprives 40% of the families of survival funds. So that's what happens. And lot are pushed below the poverty line. Millions are pushed below the poverty line every year on account of excess treatment. But it doesn't have to be. You can have a happy, relatively happy, and a bonding, as you can see here, family bonding, when the patriarch is dying. And this is very possible. This is not difficult. It's more difficult to apply technologically, excessive treatment, more difficult to sustain it than to have a humane end like this, even in the hospital setting. We do not know how many people in India want to die at home. We have very small surveys. There was one from Pune, which shows that 50% of the people want to die, but it's a small snapshot. However, if we open up the conversation, maybe we can elicit a preference for home care during the end of life, as elsewhere, many parts of the world, it's happening. So you can see this is from Randall Curtis, one of the pioneers of palliative care and intensive care environment from the US, who we recently lost, this February. So he constructed this this diagram. So how you how you manage death in the ICU depends upon the national culture, institutional culture, of course, individual institutional policy, individual caregiver and family. So there's been a huge problem with national culture and national policy as far as this part of the world is concerned. And that's reflected in this the quality of dying index, which was published by the Leyen Foundation in Singapore recently. I think it was updated in 2022. You can see India comes up 59th out of an 81 countries, and UK is at the top, not surprisingly, because they got a head start right from 1967, and a culture has been worked out. Still not perfect, however, there's a lot to learn from that ecosystem. So what is the barrier to ethical decision making in India? This is, though it's not greatly evidence-based, but it's a perspective that's grown over the last 20 years of working in this field. So there's a cultural unawareness and taboos. We don't talk about death. We think it is bad omen to talk about death. The unrealistic expectation which we share with the rest of the world, and the culture of fighting as well, we do share the rest of the world. But it's very much accentuated here because the conversation on death isn't happening. And legal inadequacies have been there. Total legal blindness to these issues on the ground in the medical world. Lack of ethical training and integration and practice, of course, both the graduate and postgraduate levels. Lack of focus on healthcare policies, and there are regulatory authorities totally blinded to this need of the dying. Institutional policies, since the private sector predominates, 80% of high-tech medicine is in the hands of 80%. They are not altruistic by and large. And physician mindsets. That is, the habits cultivated, the unresolved fears in their minds. So I'll give you a snapshot of what happens on the ground through a couple of cases, which I've handled myself. So there's a 40-year-old male with valvular heart surgery, complicated with post-op sepsis, and then 3 weeks later, multi-organ failure. Still on mechanical ventilator, vasopressors, intra-aortic balloon pump support, CRRT, and comatose. And the family was understandably anguished. They were counseled, and they were told every day that death is a certainty. We can't help. We can't really do much. They accept the poor outlook. They enter into a financial crisis, which is so common. They're unable to bear costs. And when they said, why can't we stop all this? Why can't we stop this intervention and the cost thereof? The family was told it is illegal to remove supports. Therefore, an abominable, way out that is found in our hospitals are left against medical advice. They get them to sign a document which states that I wish to leave again medical advice or take my patient away despite medical advice. Then you are absolved of all the moral responsibility and legal liabilities. So this sort of practice is extremely common in one of the point prevalence surveys, which was conducted in 2011 and again in 2019. It was seen that 5% of the admissions go against medical advice, and this 5% grew to 7.5% in the second survey. So this is not going anywhere. It's only increasing. The family was confused. It was in a distressful dilemma, got embroiled in conflict with the administrators and the treating team. And the second opinion was sought, and the second opinion was from me. also grown in popularity as an end-of-life consultant, apart from being a pulmonologist. So we all sat down, we first defined what we agreed on. Yes, the prognosis is not good. We are going nowhere. We are doing more harm than good. Then we jointly signed on certain decisions. We stop IABP, we stop vasopressors, we stop all the redundant medicines and all the tests and monitors and everything. And the patient passed away very peacefully in a few hours, and there was general satisfaction expressed by the family. So this was very easy to do, but it seemed such a mountain to everyone, in this scenario. Although it's very easy to do, very common sense solutions. So I'll tell you a case too, which is a little more complicated. And there's a 75-year-old retired bureaucrat transferred to another hospital with a weaning failure over 1 month. Several attempts at weaning failed. He was on a tracheostomy, but he was communicating. He was fully alert, very well-educated and intelligent person. He was communicative through writing and through a hoarse voice. And it was a metastatic prostatic cancer with other comorbidities, including a chronic heart failure from hypertrophic obstructive cardiomyopathy. So the patient consistently desired. Here I could get the patient's opinion directly. He would fix me with his gaze and say, "Doctor, please help me. I don't want to die like this. I don't want this ventilator. I don't want any of your treatment." And his family, which consists of his daughter, her husband, and a young child, they also were with the patient. I mean, they understood his needs and they wanted to support him. The patient had lost his wife 2 years earlier. He said, "I have completed my tasks in life and I want to really go peacefully." Initially, the team was very wary of a withdrawal decision. At that time, we had no law, absolutely no law, legal guidance in the country. But we had prognosis for immediate survival, a little unclear in the short term, so we needed time to see what was possible. So we bought time a little bit, said, we gave him a certain time frame. We will observe over a period and see if we can wean you off the ventilator, send you home. But then when the deadline arrived, he fixed me with the gaze again. He said, "Doctor, you promised me that you will relieve me of this burden. You're not as good as you were. I tell you, I sign any paper, you do it, please." So since it was a direct refusal from the patient, I latched onto that clause that consent is valid. Consent is extremely important in India as elsewhere. So we did a weaning of the patient. And since there was a refusal to put the ventilator back, we didn't do so. And we gave him anticipatory palliation and then monitored his symptoms. And he had a peaceful end, much to the gratitude of the family. So you see, such decisions are possible, but it's not being done on a large scale. Few and far between. And by and large, either you have the lama option or continuing the full support forever. So the vexed question of the law has always haunted us in the last 20 years of our advocacy for improving end-of-life care and this sort of death in the ICU. You can see in sharp contrast in the world, as Ros showed us in the northern hemisphere, you can see 70 to 90% of deaths in the ICU are through an end-of-life decision, through a treatment limitation decision. But in our setting, we had this meta-analysis a few years ago. In our setting, there are only 2 papers from us, and the dark rectangle represents withdrawal. We are so shy, so withdrawal. Whereas the world has a larger chunk of withdrawal, at least according to these data. And well, because our discourse, public discourse in the newspapers, print media, it's all about euthanasia. They confuse the whole issue of treatment limitation or avoiding excess treatment. They conflate it with euthanasia, active euthanasia, or with a pro-life or anti-life debate. So you see all these headlines reflect this fact that, I mean, they no longer think it's a medical decision or a normal medical decision, but it is a very complicated decision. And we had this matters coming to a head in the Aruna Shanbok case, 2011, with this lady Aruna Shanbok in a vegetative state ever since an attempted rape went horribly wrong, and you know, she had been in the state for 35 years when this judgment came about. That in principle, so-called passive euthanasia is allowed, provided the next of kin, and the doctors so decide, and that has to go through the High Court. So it was very complicated, unworkable, at all. In the meanwhile, the Indian Society of Critical Care Medicine had created a position statement, ethical position statement, consensus basis, having reviewed the literature of the times. And we created this flow chart to help guide all the intensive care physicians to arrive at a treatment limiting decision, be it DNAR or withdrawal or withholding. So you can see there were 8 steps, and it started with an iterative assessment of the patient's outlook, prognosis, diagnosis, everything. And then we said we must have an honest, accurate, early disclosure of prognosis. And we also said that we need to give the palliative care options to the family and discuss with them through conferences. And then we go back and forth whenever there is a prognostic uncertainty. And then consensus through open, early, repeated discussions, ensure consistency within the team, transparency and accountability through documentation, and then withdrawal and withholding, later compassionate care to the patient, and patient is gone, then family and bereavement care. So this sort of thing was later, there were iterations, 2 iterations. There was 2012, and then this expanded to a combined statement of Intensive Care Society and the Palliative Care Society of India. So an integrated care plan for the dying, it added the palliative care 4 steps of it. And this is available in the public domain. Then we also have an advocacy group called LIcit, End of Life Care in India Task Force, between the Medicine, Indian Solution Palliative, and Indian Academy of Neurology. And this advocacy has been carrying on since 2015. We've written in the public domain, in op-eds and all that. Let's talk about death and so on. And then we also had the civil society involvement in our discussions and call to action for ensuring humane care at the end of care, end of life. This is the Mathura Declaration of 2018. In 2018, we had another development, which was a path-breaking development for India. So this is called Common Cause versus the Union of India, where the validity of Advanced Medical Directive and for legally appointed proxy was established, and they also established the legality of withdrawal and withholding decisions. It decriminalized it very clearly, based on autonomy and based on privacy, which is an inalienable right for the Indian citizen. But what it did in principle, it undid in procedural guidelines. They made it mandatory to have a 3-step procedure, which involved not only the local medical panel, but also a bureaucrat established panel, and further on, final sign off by the district magistrate. This was obviously just not on. Nobody has used this provision at all. We continue to take end of life decision. I and some of my colleagues, we had continued to take according to the Indian Society of Critical Care Medicine and IAPC guidelines. So since that time, 2018 to 2020, all these developments have taken place. We worked with ICMR, Dr. M.R. Rajagopal and myself and colleagues, we worked with the ICMR to provide definition of terms used in limiting life support and all around end of life care. There were 25 terms which were redefined through consensus and updated, because everything was put in the one dustbin, whether it's DNAR or withdrawal, in one dustbin of euthanasia. So complete confusion with active euthanasia. So we also had a DNAR guideline by the ICMR, Indian Council of Medical Research, which is a statutory body. And there's a Blue Maple publication from the Manipal group of hospitals, and also institutional guidelines on end-of-life care from All India Medical Institute. It's a premier, government-run institution, teaching hospital. We also had the complicated procedure for executing an advanced medical directive, which also needed sign-off from the magistrate. So the Indian Society of Critical Care Medicine and the LIbby Center for Legal Policy, which is a legal think tank, we appealed for simplification of these unworkable guidelines, and this was accepted. In January this year, I'm happy to declare that it was much simplified, although it is not quite there where we wanted it or what we had fought for, but it simplifies to a great extent the present legal framework. So what it does is, so this is where we are, intersection of the medical and the legal world in the Supreme Court. So whereas we needed endorsement or validation by a magistrate for an advance will, now we don't need that. We just need to notarize or having a gazetted officer, which is much simpler. Then we have this flowchart now. This is in a nutshell, how we execute an end-of-life decision. I'll project it more closely. So it is only for those patients who have lost decision-making capacity and are terminally ill. This is a proviso by the Supreme Court. So the treating team should be satisfied of the above two conditions, and that further life-supporting treatment would not be beneficial to the patient. So this is they refer to a primary medical board consisting of the primary treating physician and two subject experts of more than 5 years experience. Then once this is done and they speak to the family and there's a consensus emerging, they have to get validated by a secondary board, also within the hospital by 3 independent physicians, however, one of whom have to be appointed by the chief medical officer of the district. So they needed one representation from the government. So this is the problem. There is basically all this stems from a distrust of the caregiving team, both the professional caregivers and the family caregivers. So they want some oversight. So this is what we could not convince them to let go. However, this is doable because you can empanel some permanent members for an EOLC board by the chief medical officer within the hospital or institution itself. And these decisions, since they are time sensitive, the Supreme Court has said you got to convene and decide within 48 hours. And then once this is the secondary board concurs with the primary board, you just need to inform the magistrate, but you carry out the decisions. So in case there is dispute, then you can go to the High Court. So I want to conclude this by saying a conversation which began years ago, 20 years ago, has gathered energy. There is some significant advocacy here. And here, the medical and the legal worlds have come together at several levels. We are fighting this cause for this cause. A change in attitude. We need to work at the community level. We need to work at the family physician level, so to speak, and hospital physician level, to bring about a change in attitude, which would be a prelude to change in the culture of caring in the country, and which will eventually reflect in practice. We can foresee the potential benefits of the recent amendments by the Supreme Court, but we must find pragmatic ways to translate it on the ground. Thank you very much for your patient hearing.
Thank you, sir. I think we will move on to Dr. Libby's presentation. Dr. Libby, it's over to you.
Many thanks. Let me just share my slides. Great. Is that all coming through clearly? So it's great to be able to follow Ros and Raj around some of the big things, the big themes that they've highlighted globally, really. And I'd now like to talk a bit about an endeavour that has been mentioned by Ros earlier, and I worked closely with Ros and Professor Raj Gopal over the past 5 years now. It's been to really knit together a lot of the themes, the challenges, the different strands that have been mentioned globally when we begin to look at death, dying and grieving in their broadest form, not just through a healthcare lens, not through a palliative care lens only, but through these broad lens, understanding them as the societal events that they are. So I'm going to talk through about the reason that the commission was started, some of the key thinking and data that we compiled, and then talk about the future and talk about what a new vision for the future could be, and of all our role in it, because within palliative care, we have a very powerful role. We have a powerful voice. It wasn't powerful so much in the past. It's becoming increasingly powerful. But we are still a small minority, but we're the people, we're the keepers really at the moment of death and dying. And we need to broaden the number of people that we are speaking with, and we need to strengthen our voice. So that's where we will come to at the end of the presentation. I'll leave some time for questions because I see there's been a few things in the chat. So I'll finish before the end of our, to give us some time to hear from you guys reflecting on what you've heard in this session. So for many people, the Lancet is about data, studies, health challenges. And so the idea that they did a commission on death and dying for many seems odd. But the impetus, the reason why this topic was chosen and why it was deemed to be important was because of this idea that death has become over-medicalized. Now, this was thought initially to be a challenge more of high-income countries, but as we found, and I'll go through, this is actually a challenge globally, and not necessarily only of the rich, although that is where that's often coming. Often the out-of-pocket expenditure of communities who really don't have the funds to pay for this also is contributing to death becoming over-medicalized. So we'll talk a bit more about that. And also when we begin to drill down into it, things are not as simple as we might have thought when we started. So looking at death and dying in their broadest sense, they are core universal concerns. They will affect every single person in a population, in a society, in a country. So it always shocks me to think why we don't have a public health response that recognises this, because for other events that are universal, that affect everyone and cut through populations, these are recognised by public health, by government officials, but here that is not. And what we know is how people are dying and have died is changing significantly and over just the past 2 generations. And if you think back, all of us, to our grandparents and how they died and their peers, things are hugely different to how they're dying and how the next generation in front of us will die. In some ways, some of the changes have been for the better. People are dying later in life, although, as Ros highlighted, the time or the length of life you have is often outstripping the quality of life and the chance to have a healthy life expectancy. So life expectancy and healthy life expectancy are not keeping pace with each other. And some people have access to pain and symptom control, holistic care as they die, although we know that many more do not. But some changes have been for the worse, and dying is often now prolonged. It's taking place in hospital, and we know that people wish not to be there in their final days. And families and communities increasingly say they feel unprepared. Death feels unfamiliar to them, and they feel unable to manage and cope with these events. And so that further fuels this dependence really on professionals and hospitals at these times. I'm going to look at just a couple of the tables, some of the key figures that we pulled together to illustrate contemporary dying. So what's it like dying across the world in the 21st century? So as you mentioned, there's a global success story in some ways. It seems to be good news, but we know that there's disproportionate progress in life expectancy. And there are actual reverses in for certain groups. So, for example, women in certain groups in the UK, their life expectancy is stalling whilst other groups are increasing. And in certain places in the US, for example, women with a lower number of years of education and from certain minority ethnic groups, we see their life expectancy gains reversing. So they're losing pace with that whilst others are increasing. So what's happening there? We know there's a shift in the burden of disease from communicable infective disease to non-communicable diseases such as cancer, heart failure, renal failure. And we also know that this shift is accompanying a significant burden of suffering, and using the term serious health-related suffering to understand that specific term. And that's not only for those who are dying that year, that is for people who are living with these incurable illnesses. So there's a huge mandate for change. How things are going at the moment present a serious number of issues. This is one of the tables, the first table, where we just look at data for people who were involved in the commission, so commissioners. So there was a primary care physician, Luxon, in from Malawi. I was there from the UK and Ros. And here we can see almost 2 decade difference in life expectancy. So there's certainly not one story that we're seeing. And we picked up a range of other differences here around maternal mortality, deaths from suicide, deaths from non-communicable diseases, and number of people with serious health-related suffering. So it's not one story within countries, and it's certainly across countries, and it's certainly not one story within countries. Huge differences exist within countries and between countries. This is looking at place of death, for which data mainly comes from high-income countries, because there's not the data available in low-income countries, and only one middle-income country represented in Mexico. But this was a series of reviews trying to understand where are people dying, for where data is available. And here we can see there's the great majority are dying out of home, so not at home, but in institutions, be they hospital, care homes, or other long-term care institutions. And this is a trend that is increasing. We see this globally in high-income settings and in some middle-income countries for which there is data available. So where people are dying is changing. But what we see, along with this idea of the over-medicalization of death, which is much spoken about and is a very serious issue, so over-treatment, both with economic and climate change consequences. But we also see on the right-hand side, the slide that Ros showed earlier, the significant under-treatment when people are dying. And this is in terms of pain control, as simple as managing pain and availability of opioids per person who's in need. And we see this huge inequity with bloated US and Canada and entire continents reduced down to a single line with no availability at all. And we also see this in terms of avoidable mortality. So people who are dying from what could be a curative illness if they could access the right healthcare. And this comes down to the much broader issue of equity and inequity in healthcare and the social determinants really of how, when, why you're dying. So it's not as straightforward as to say death is over-medicalised. In many ways, it is under-medicalised or under-treated. But what we can see is there's a huge disparity in the type of treatment that we would need and access to all forms of healthcare, be they palliative care or preventative healthcare. So not as simple as saying it's over-medicalised. We were challenged by the editor, Richard Horton of The Lancet, to not only rehearse and discuss the challenges of contemporary death, dying and grieving, but to look forward, to be hopeful, to think about where a new vision may be and how some of these challenges may be overcome. We used the term a realistic utopia, and this is from the philosopher John Rawls, the US philosopher. And this is a way of imagining and visioning a radically different future, a radically different society. So it must be practical and achievable. It's not so radical that it is unachievable, but it's thinking bravely, confidently about a new vision and then drawing down the principles that you would need to make that vision a reality. So that's why it's called the realistic utopia. So through the Commission's work, we came up with the 5 principles that we feel would lead to a realistic utopia, a new vision for dying, grieving and caring well. And I'm going to go through these 5 principles now with some examples of how these might be enacted or some of the challenges and barriers that we would need to overcome to get these to be a reality. So the first is that the social and structural determinants of death, dying and grieving are tackled. And what we know is that the determinants of health literature, social determinants, has become something really common. We all now really understand that health is not only made by healthcare professionals, by doctors and nurses, tablets and outpatient appointments. It is determined by the air we breathe, the food we eat, the relationships we have, the home that we live in, the ability, the control over our lives to make choices about where we work, how long we work, who we associate with, etc. So we know that these broader determinants have a huge impact on the well-being of people. And so that's really transformed the health and well-being ideas, really, because you don't just need more services, you need healthier environments and people to be able to have the literacy to make their own decisions about their health. And we know that how people live affects how they die. But this often is not as acknowledged. Often when someone's dying, they're taken off and seen in ITU or seen in palliative care, depending on how lucky they are. But often these broader determinants are not taken into account. But how people have lived determines how they'll die, often what they'll die from, where, and their ability to have a good death for whatever that may mean to that person. And so that will then influence the type of dying they have and the grief and the bereavement of the people around them. We know that how people grieve is also socially determined, what resources, networks, friends they have, what coping strategies, how they've dealt with challenges before, and their ability to deal with that grief and how it is managed within their lives becomes a determinant of their future health. And we know that there can be huge health implications for poorly managed bereavements. Will they return to work? What new relationships can they form? Can they incorporate that grief into their life and rebuild their life after that, or can they not? And that then is a determinant of their future health and well-being, which in turn goes on to affect how their death will be. So it's this cyclical nature that we need to understand, rather than thinking of death as something quite separate that happens and needs a medical intervention to manage. This is an example of Compassionate Corral, which some of you may know, one of the biggest, a big project recently looking at developing palliative care in one of the biggest slums in Dhaka, outside Dhaka in Bangladesh. And here, obviously, the social determinants of health are very clear and very live. Access to water, access to safety, to housing, to shelter, yet alone medication and healthcare services are very different. So the palliative care service needs to work through the existing structures, the existing determinants that were already influencing people's health. And working through that allowed them to develop and deliver an appropriate palliative care service for the people in that slum, through the participation of volunteers, all of whom were also living in Coral slum. So here we can see a palliative care service that's developed in line with and simultaneously going on to address some of the social determinants that are causing poor deaths, rather than coming in as a kind of separate point right at the end to deliver a separate service. The second is that dying is thought to be a relational and spiritual process rather than simply a physiological event. Now, speaking to palliative care doctors here, obviously this is something I would hope we would really understand and have as a core part of our practice. But often the relationships are not focused on. Often it's around getting the right medication, and I run a community palliative care service. Often we're so focused on getting the right equipment in or the right services in that we forget that they are not ends in themselves. Relief of pain is so important, but it in itself is not an end. That is removing a barrier to a good death. The main aim of our services and our care at the end of life is to remove barriers, to then allow people to do the real work at the end of life, which is building on relationships, having the people who you care about with you, saying things that matter, reflecting on your life, coming to terms or otherwise with what's happening, getting the right hospital bed, getting the right injectables in, removing pain. These are all essential parts, but I see them as part of the jigsaw, all of them essential pieces on which the real work takes place. And as healthcare professionals, we can't do that real work. That work is due to the individual, the family, the community, people around them. And so it's important to understand our role in that, rather than thinking our role is actually the main purpose of care and work at the end of life. This is one of the projects that was mentioned at the beginning. So this is based on a lot of the compassionate communities work in Kerala, which I've been involved with and learning from for many years now. And this was my attempt to understand the translation of principles from Kerala to London. And I did my PhD evaluating this new project that we set up, Compassionate Neighbours, which is focused on the relational aspects, relationships at the end of life and the importance of them, either building ones for people who do not have many relationships, or nurturing and building those relationships and supporting those relationships for people who do have them. The next principle is understanding this idea really that it takes a village to raise a child, a term that is often used and applied to palliative care. It takes a village to support someone to die. And obviously that village is a metaphor for a group of people networks. And what we know is that it's not only having a great doctor, a great nurse, a great family carer that will make the difference for someone who is caring or dying or grieving. It's the integration of all of them. A good team, depending on what that person needs, is the essential part. And for too long, we're looking at getting the right services or supporting a family carer separately, rather than thinking of the links that need to happen across this system. And this image from a piece of research from some great researchers in the University of Western Sydney, Debbie Horsfeld and team. This is a brilliant report if anyone would like to read it. They looked at when it works in a community, when people are dying well at home, what lessons can we learn? So it's called an appreciative point of view, where you go to see what works and then work back to understand what principles informed it. And here the red at the bottom is the carer, with all the blue friends and red community members and other friends around them. And out here in black are the distant palliative care nurse, the doctor, the community nurse. And this is a problem. This does not mean that they are well integrated. They don't know what the reality is for that carer, that person. So how our job as palliative care clinicians is to start addressing this map, because I guarantee the work that you're doing I'm similarly in this map. I'm out on a limb. Our work is to begin making some of those links, understanding what the reality is for that family, that carer, that patient, and putting yourself back in to understand and support what work is going on there. In the Commission report, we found many examples where reports on frailty, COVID-19, end-stage liver disease did not mention anything around death, dying or grieving. It was as if these life-limiting events would never lead to that outcome, or it was taboo to mention it. Who knows? We'll never know why they were not mentioned. But this then creates a huge gap, a void, where strategies, policies, other health teams, other social teams are unable to then respond to this. And in the UK, the palliative care often death and dying comes under the subsection of palliative care that comes under personalised care or non-communicable diseases. Death is not seen as something that is a societal event that everyone has a stake in. And this is an example of the social determinants of health model. And I don't know if you will have seen some of this before. It takes the life course approach, where it looks throughout the whole life course of how different things improve or damage our health and our well-being. But interestingly, death and dying is not included in this. It just ends at retirement. And this is just another example of the omission of death and dying in policies, strategies, narratives, and even in public stories. And Ros mentioned about Catherine Mannix, who's become a very influential speaker on death and dying in the UK and increasingly globally, where she talks about just the loss of our skills in understanding everyday or normal dying, not sensationalized front page media stories or in films, just people dying of common conditions at home or in hospital. And we need to bring that back. So we need to end this silence on death and dying and bring it back into narratives in our society. And this is an example of how we can begin to understand communities' understanding around death and dying from using the term death literacy. And this is increasingly a term used to understand communities' knowledge, experience, and confidence in dealing with death and dying. And this is there's a tool that you can that can be used to assess people's understanding and confidence in this important domain, because the idea is that something has been lost. The final slide, the final principle is around probably the most abstract to understand, and this is around death having value. And this isn't to say that we want death to happen or that we're ignoring the sad, distressing side of death, but it is rather saying there is an inescapable part of our human life, which means we need to understand the role death has. Death is part of life. And by ignoring it, by fearing it, and by trying to push it away and devaluing it, we are denying that crucial part of the picture of our lives. And by caring for people at the end of life and understanding and recognizing the role death plays, then we have an understanding of our fragility, our commonality, our shared dependence. And so by promoting discussion around it and an understanding of its natural part in our lives, then we can again revalue death and dying and begin to challenge a lot of the challenges that Dr. Raj Mani and Dr. Ros have spoken about today. So examples of this exist around the world. I'm coming to the end now. This is my favorite table in the Commission report. It's table 5, which is looking at all the ways you could begin to shift death and dying globally, with some ideas of how you could change the systems really within which they exist. And down here on the right, examples of where this is happening already. So I won't go into those now, but it's a really great read, and I'll share the link in a minute in the chat so you can have a look at some of that. So to close, our final, the key messages from the report. Dying in the 21st century is a paradox. People are both simultaneously overtreated and undertreated, and this happens within the same hospital, yet alone across countries. Death, dying, and grieving today have become unbalanced. And we make some links to the climate crisis. The idea that we can beat death, we will eventually control death, overcome death, is the same that we're in control of and not part of nature. Rebalancing death and dying depends on changes across death systems, and the disadvantaged and powerless suffer most from how these current systems are not set up to deliver the best care. 5 principles of the realistic utopia, this new vision of how death and dying could be. I've gone through those. And the challenge of transforming how people die and grieve today has been recognised and responded to by many around the world. That table goes through examples of that. It's really inspiring, I find, to read that. But more concerted action is needed, because these are isolated examples and radical changes across systems are needed, and they are a collective responsibility. And it's our job within palliative care to get more people to join this discussion so that it's not only our voice asking for these changes. So that's the QR code if you'd like to read the report. And the final really conclusion is death and dying must be recognised as not only normal but valuable, and care of the dying grieving must be rebalanced. Many thanks.
Thank you, Libby. So the session is open for questions. Anybody?
Hello, sir.
Yes, Dr. Kevin.
Sir, actually, very good presentation by all the three legends in this field. But I must, ma'am, spoken about the death literacy and about speaking. We should start a conversation regarding the death and its allied aspects like grief, etc., etc. So, how anyone can start a conversation regarding death, like whenever in this Indian scenario, in Indian context, whenever we start with whenever we begin a conversation regarding death, it will be taken as a negative connotation, a negative sign. So we how to overcome this barrier and how to begin with to start a conversation. Thank you.
Well,
You
it's
start.
okay. It's different with every person and family. And I think, first of all, the best thing is probably to get to know the person who is ill and the family and find out what they are thinking. And what do they think about prognosis? Because often I'm really surprised when families say, oh, I think he's only got a few weeks. Oh, I think he's dying. But sometimes it's the other way, and people think they have years to live when they only have weeks to live. So I think it is about brave conversations and challenging. So if they do think that somebody should go to intensive care and be ventilated, we need to explain the limits of medicine, because we as doctors or senior nurses, we know the limits of medicine, and we have to share and to explore people's worries. But I realize it is a stigma in your culture. It's probably less of a stigma where we are working. Those conversations are getting easier, particularly probably as people are more frightened of institutions in the UK, certainly, and they don't think hospital is always the best place to be. So it is about changing expectations, or finding out what the expectations are and then narrowing the gap and finding the courage within yourself to challenge.
Raj,
And
I
Yeah,
think,
ma'am. Yeah, ma'am. That's a great thing, and it is much easier to start a conversation with the people who are in the end of life or who are already struggling with the end of life. But yeah, the otherwise, in a healthy person, how easy it is to have a conversation regarding death and its allied aspects.
well, Libby, you can answer that.
well, I think I was in a meeting earlier this week, and we were talking around about like bowel cancer screening. They were saying, well, everything, I don't know what happens in different states in India, but in the UK, people are really aware that you should have screening at different stages for different conditions, and bowel cancer screening. Everyone gets a letter, I think, is it over 70 or something, to say 60. To be invited to come 60 to come for screening. And we were just saying, people don't find that distressing. That's not upsetting. Yes, of course, the idea of bowel cancer is very upsetting, but actually preventing the suffering around it, or potentially this is maybe a cure if you had it early, then people find that that's helpful. And we were wondering, and I think Kath Mannix, who Ros and I both mentioned, has discussed, this similarly with having a will. Is that something distressing? Because that makes issues for your family much easier if they're then trying to manage after someone dies, the estate and those kind of things. And so we were talking about, people can access the idea of the future and of making decisions for the future. And could everyone be given the opportunity to make a will or to think about the future at a certain age as a kind of public health intervention? And that may destigmatize it, because this is saying, this is a reality. We don't know what's going to happen in the future. It's not saying this is going to happen at a certain time or causing a distress like that. But I quite like that idea, because that way you speak to everyone in a population and give everyone the opportunity. It's obviously very different when you're talking with someone who is dying, who has the reality of that short prognosis and the emotions and things that go with that. And that then, I mean, as Ros was saying, that's how you then have a very different quality of conversation. But I think it's less, what we need to take away is this isn't about whether this will happen. This is about when this will happen. And I find it so surprising that still there's that thought that this probably will never happen. And that's just our modern day society, this idea that we'll beat death. Front page news is always about the newest cure for dementia, etc. And actually we live in this kind of slightly deluded world where we think this won't happen. And that the problem is it is upsetting, and that's due to, you know, death anxiety. And we talked about that in the report. You know, you can understand why people find these topics distressing, but that doesn't mean we can't bring them up, because by not talking about it, when it does happen, it makes it even more distressing.
And spending more money doesn't always buy more good life.
Absolutely not.
It's
Yeah.
a myth that if you approach the subject of death or discuss death, anxieties increase. I don't think so. Actually, in opening up, the anxieties reduce.
I think
And
so.
around the family, around the patient, the family is going through a lot of unspoken distress. And you allow them speech, you allow them to voice their concern, and you support their emotions. Then it goes a long way in reducing anxieties, improving pragmatic decisions, and post-traumatic stress disorders. So I think we are going by assumptions rather than by evidence. Doctors, you know, and we, more often than not, we need to initiate these conversations. We can't be playing a waiting game, you know, shadow boxing and using euphemisms. We've got to be frank. And part of compassion is openness and frankness. It's not compassionate to hide facts, is it? Compassion is to open up facts, allow people to open up and express themselves. I think this sort of cultural change is required at the medical practice level, at all medical practice, community practice, family practice, and in the hospital. Now, with the legalization of advance will, we must promote this idea of advance will for two reasons. We can also, around it, promote advanced care planning. So advanced care planning as a culture, as you know, that can only happen with a conversation about death, and that doesn't need to involve the physicians. It can be through other caregivers as well. So we must promote ACP as a society, as a professional. We must do that, and maybe these conversations will take root, and a new habit will form, right, of talking freely, openly.
Yes, they should be kitchen table conversations, and you can always change your mind for as long as you have capacity. But I think in India, what I've seen is that the younger members of the family often say, don't tell mother or father how ill they are. And as you say, Dr. Raj, most people are relieved to know. Most people don't die of bad news.
Yeah.
And maybe it is just about honesty. And I think, you know, we're all capable of honesty.
It is. You know, I think that assumption isn't true for the majority. I only find in my own practice in the minority of hiding facts from the patient. And when they do so, we ask them, why do you say so? Why do you want to keep your father from this news? Can you share with me your concerns? I think they need some sort of a talking. They need a bit of healing too. So if they overcome their fears and their complicated grief, then they might be able to open up and then do the right thing. I think we have to venture to talk with them, even though it's culturally a little risky. We must take the risk. It's worth it.
And I think you're right. It's the word brave. You know, we're often holding information that they don't have, the family or the patient. And I often feel when I'm about to start a conversation with a patient, it's nerve-wracking. I'm going to upset them. There's going to be tears. But what it's not me upsetting them. It's not my information to withhold from them, actually. And I think this paternalistic issue is really challenging. It's their information. I happen to be holding it, and they deserve to have the right to hear it if they want to. And because during that disclosure of that information, there may be tears, but that doesn't mean it's the wrong thing to do. You know, these are upsetting topics. It's okay to be upset, and our job is to hold them and support them. But the withholding of that information is not ours to withhold. You know, it's theirs, and so that's
for
what
us. Yeah.
we need to be clear with.
Anybody else have any questions?
So one thing which I have observed in my practice is that though death is generally a taboo which is not spoken very openly, even when the patient is in an advanced state of illness. But once if that topic comes about end-of-life care and terminal care, and we explain to their relatives or the caregivers what is eventually going to happen and what is better for them, rather than taking them to the ICU and putting them through all this harrowing treatment, which is of little value, they definitely come to accept that. And once if they accept it, then it is a big relief for them in knowing that this is all what they need to do. Just be with the patient with support and care and love in the house if possible, or in the hospice if needed. Most of them prefer houses, especially after COVID. What I have found is that people in India have started accepting death as a part of life, because previously they were all taking even the very old people to ICUs at the drop of a hat when they had some problem. They have stopped doing that, or rather they are waiting for the right advice to keep them in the houses and take care of them in the houses. So that acceptance is slowly seeping in.
That's really interesting, because we've been looking at the impact of COVID on attitudes to death and dying. And I think in the global north, or certainly in the UK, I don't think it has made people more accepting of death, more frightened of hospital perhaps, but not more accepting of death. So I'm glad that one good thing has come out of COVID, not many good things.
Madam, that might be because of the fact that there is a cultural, acceptance of death also in India. Because, for example, like my grandfather or grandmother, they were never taken to the hospitals. We accepted the fact that they have to die in the houses. And what happened is, if I can enumerate that, like in my childhood, we did not have ICUs in the hospitals. I mean, my parents were both doctors, so I know. So there was no ICU in the hospitals. So most of the time when they very terminally ill patients, they go home to die. And that was accepted fact. But in the past 30 years, the scenario in India has changed, where we have technologically advanced very much. At the same time, people also have the money to go for it. So economically also they have advanced, technologically also they have advanced. So that was the effect of people accepting to go to the hospital for terminal care and being in the ICU. They thought that was the best thing to do until COVID came. And so then there was a sudden, shift of paradigm because of the necessity or the lack of treatment, of not knowing what to do. Especially the old people are kept at home because they were not accepted in the hospitals. They were not allowed to go into the hospital. So they had to be in the houses almost for 2 years. Many of them passed away. But then that gave a time for the families to understand the old values. And they started accepting that once again. That's what I believe I have seen. Because that, right now I can talk to the families, even if they are not accepting the fact that, the person has to die. The stigma is that, what will the others think if I keep my father dying in the house instead of taking to the hospital, instead of the fact that, they don't want to take to the hospital. So that is why they took to the hospital, not because they want to. But if you make them understand that, no, there is no need, because there is very little better outcome than this, because the person is in a terminal stage, especially for cancer. But even for end organ failure, we do that now, and people accept that. I
Good.
feel that it is more difficult to convince the doctors in as accepting palliative care rather than the families trying to convince the families to accept it.
Yeah, and cancer treatment is changing with immunotherapy. People are living longer. They can have treatment at home. It's very expensive, but yeah, they're living longer, but often with complications and symptoms and distress and uncertainty. I think oncologists accept palliative care in the UK. I don't know about heart specialists and kidney specialists and respiratory specialists.
Very slow to accept. But then again, are we not sacrificing the quality of life of the patient by prolonging the life? That is my take on that. Like immunotherapy, which is so costly. Even here also, we advocate that for people who can afford it. But I've not seen a real change in quality of life for these patients, because most of them cannot complete the treatment and they usually die of renal failure or some other complications.
See, I must say the COVID situation was an opportunity lost. Okay, we temporarily realized the value of reasonableness in applying technology. We had suddenly a shortage, even of oxygen, and we leave alone ICU beds. So then we had to willy-nilly sort of do rationing, which is unthinkable in normal circumstances. And then obviously the old and the infirm were the low priority in accepting patients. So it happened willy-nilly, and it didn't come as with a clear policy document. Number two, to say that now, of course, there is a larger middle class, affording middle class, but it's only accentuated the inequities, which was alluded to by Ros and also by LIbby. We are not thinking inequities. We are only thinking about the affording population, right? And together with the middle class, there is a lower middle class who aspirationally come to a hospital and access expensive care, but it breaks them financially. And this also we see. And there are clear data that millions are actually pushed below the poverty line because of out-of-pocket catastrophic healthcare expenses. This is a fact, well documented fact. So you see, putting it all together, there is no escaping the fact that we have to reorient ourselves to conversation about death. And around it will be fiscal efficiency of our healthcare. It is humanity at several levels, okay? On the ground, on an individual level, and at the community level, better utilization of resources, and of course, not misutilization, and reducing this gap, inequity. All this is extremely important in healthcare.
Okay, Punita, you can ask your question.
Sir, my question is regarding death at home. Like, for example, some 3-4 months back, we had a meeting in our college where all faculty of the college are sitting, from senior professors to mid-generation people to young generation doctors. So many of the seniors, including, they are afraid to sign a death certificate for even an old person, 94-year-old, passing away at home. Even if they know that if they are under their care, many are obliging to sign the death certificate. Otherwise, they generally advise not to sign the death certificate because there can be complications behind it. I find this as a barrier for both in urban and the rural population. So people want everything to happen at hospital so that your death is certified easily.
Yes, that's a problem, and that's why many people come to hospital when the patient is end of life. only just to get certified and to get the certificate as to the cause of death. But it is not necessary that patients should come to hospital. And actually the act which is in India does not ask for a certificate from doctor to register the death actually. So it is because of the people are not aware of how to register death and things like that. That's why it is happening, I think.
So it is true, sir. Actually, only during the COVID, we needed to have a doctor certificate saying that the patient does not have COVID so that he can be straight away taken to the crematoriums or of a burial. But after that, there is no need for a death certification if the patient has died at home, because most of the time when we are taking care of the patients, end of life care patients and terminal patients at home, sometimes they die and then they call us. But even if they are not our patients, we go and certify, and that's confirmation is given, and then they can go to the next day to the municipality or the councillor, and through the councillor they can register their deaths, and it's quite easy. They don't need a hospital certification. That's what is happening here in our place. I don't know about the rest of India.
Okay, I think we have to wind up the session. So thank you, Dr. Ros Taylor, Dr. Raj K Mani, and Dr. LIbby Sallnow for enlightening us with the different aspects of death and dying happening across the globe. And thank you for finding out time to speak to us from your busy schedule. So thank you everybody for being with us. And it's over to Sri Priya.
Thank you. Thank you all the eminent speakers. It was really enlightening and an experience of a kind to be listening to.
Thank you all.
And thank you everyone for making the interactions active. And without much delay, I would just be signing off because it is almost a day end for the Indians, and I believe it is day half for Dr. Ros and Dr. LIbby. So happy day to you all. And take care everyone. We will, with a promise that we will see you again in another interesting session with other eminent faculties. This is Sri Priya signing off with all the eminent speakers and Dr. Sunil Kumar from the Pallium India's presentation desk.
Thank
Take
you.
care everyone. Bye-bye.
Thank you.